And it looks like it's 7 p.m. So wonderful. Thank you very much. We've got a small but hopefully enthusiastic audience joining us this evening. And we'll have just a little bit of a run through. And then if there are any questions that you might have, then we'll be happy to entertain them. Reminder, this is who I am. I'm the medical director in the Cardiovascular Rehab and Prevention Program. And in times before the COVID pandemic, you may know that we actually ran programs exclusively for people living with diabetes, as well as persons living with heart disease. And of course, there's an overlap between the two. So we're going to jump in and talk about some medications related to diabetes, and then importantly, some newer information about how diabetes medications, certain ones may actually have unique effects with regards to the heart, and why these days some medicines might actually be preferred over other ones if we're thinking about heart health in addition to diabetes sugar control. This slide reminds us of where medicines and other kind of interventions fit into our kind of joint activities within the cardiovascular rehab program. That is, if you're living with diabetes, we're interested in managing sugar to treat to manage your diabetes and avoid complications. But we're also interested in interventions that can actually help protect your whole vascular system. So that includes blood vessels of your heart and of your brain and of your legs, and the ones that provide blood flow to your essential organs as well. So this is a sort of a memory tool that comes from the Diabetes Canada guidelines for professionals that reminds us that we should go through our ABC, DEs, and think about all of these issues when we're approaching decisions or discussions around medications. And it reminds us that, yes, we can certainly use medicines as well as other important interventions like physical activity and nutrition to make sure that our sugar control is as good as it can be. We'll use similarly medications and lifestyle measures to get our blood pressure under good control. Well, let's not forget that cholesterol is very important, not only for persons who've had a heart event, but also for persons who are living with diabetes because of the heightened risk of developing heart problems down the road. We would suggest that you actually have the same target same stringent target for control of LDL cholesterol, whether you have had heart issue or whether you're living with diabetes. And certainly if you've got both of them together, then it makes it even more paramount that we get these levels under control. There are certain drugs, that may uniquely protect the heart for persons living with diabetes. And we'll just make sure that we don't forget about these things. And under the A category, these would be ACE inhibitors or angiotensin receptor blockers. And when we previously talked about medicines for the heart, we'll remember that these are the medicines that influence the angiotensin pathway. Angiotensin is that hormone in our body that makes blood vessels squeeze down. And that's not a good thing for blood pressure control. It's not a good thing if our hearts are in trouble. But what's also very interesting is that having these medications on board, if we're living with diabetes, will actually protect our hearts, and they'll also protect other organs like the kidneys. And some people with normal blood pressure living with diabetes, they may be recommended to go on one of these things, again, for protection of the body. Don't forget the statin, because that's what will keep our cholesterol under control. Don't forget the aspirin as well. And we spent a lot of time talking about aspirin and how it can have this small but very important effect on keeping that blood a little bit thin by keeping our platelets less sticky. And for persons living with diabetes, certainly with vascular problems, that aspirin is definitely part of the cocktail that will keep us protected. And then we're going to talk about these specific types of diabetes medications that have also more recently been shown to provide cardiovascular benefit, that is protection of the heart, if you're living with diabetes. And they've now moved up the cascade in terms of preferable choices or preferable options to help not only sugar control, but also protection of the heart. For under the E category, don't forget exercise and healthy eating. We all believe that those are critically important. They're not a replacement for medicines. They make medicines actually go better when we do all of it together. And the S reminds us to not forget about smoking cessation. And again, very important if we're living with diabetes or if we're living with heart disease, that if you do smoke, that stopping smoking can be one of the most important things that we do. Okay, so there's a lot of great studies that have looked at people living with diabetes over time. And what this slide lays out for us is the relationship between sugar control, that's what's expressed on this lower axis, and this represents the number that's known as A1C. If you're living with diabetes, one of the parameters that you should know very well for yourself is what is your hemoglobin A1C number. That's like your 3-month average blood sugar. And for persons who do not have diabetes, the A1C number is less than 6%. And you'll see that on this axis is expressed the risk of developing coronary artery disease. And you can see for this group that have A1Cs less than 6%, their risk of heart disease is in fact the lowest. But as the A1C starts to go up, the risk of developing heart conditions goes up dramatically in both men and in women. And for persons with A1C above 7%, this is when our risks are indeed the highest. So the recommendation therefore is, where possible, if you're living with diabetes, let's try to get our average sugar level over 3 months down below 7%. And for some people, even down below 6%, as long as the rest of the system can actually tolerate sugars that might go too low at times. So this is the information that guides the target for sugar control and emphasizes the point that the risk of cardiovascular disease rises as sugar goes up. Okay. So to get sugar down, we exercise, we eat well, and we make use of medications in a judicious fashion. And the lovely thing about diabetes medications is that you could take more or less depending on your body's response to the lifestyle factors coupled with the medications together. And hopefully you get into a positive kind of cycle in that as sugar control gets better, you're feeling better, you're moving more, you're eating better, sugar control gets better, and you cycle that way, and actually the needs for medications might actually come down. When we decide which medication might be the best option in any particular situation or for any particular person, we'll think about how that medication might actually impact on blood sugar. Some medicines have a mild effect on sugar and therefore mild risk of sugar going too low. Some have a stronger effect on sugar, but they may also have a risk of pushing the sugar down too low and not feeling well. So we have to gauge that depending on where you're starting with your sugar levels. Some medications we've already alluded to may actually offer some protection of the heart and the kidneys over and above their effect on blood sugar. So that might influence our choice or recommendation. We'll think about side effects as well. And we know that side effects are very important to our patient partners who are living with diabetes. And we'll think about certain diabetes medications that might make blood sugar go too low. You may have heard the other term for this called hypoglycemia. And also weight gain, that some medicines, as a byproduct of pushing sugar down and into cells of the body, they may actually induce some weight gain. And obviously that's not a desirable outcome, especially if that goes up substantially. Other choices for medications may be guided by the route of ingestion. And I'm certainly aware that, some of our medicines will come in pill form. So we just have to take them once or twice a day, or and now increasingly, sometimes even less than once a day. Similarly, there's injections like insulin that might be taken once or even 4 times per day. Other kinds of newer injections might only be taken once per week. So all of these factors will influence what the best option might be in any particular scenario. There are many options when one kind of lays out the entire landscape of diabetes medications. We didn't list out all of the different kinds of pills and injectables that might be available. This table that comes from the practice guideline from Diabetes Canada, this is what the diabetes educators and nurses and physicians and pharmacists will refer to. And you'll see that medications are kind of grouped together in different classes according to how they might work. And they've got these sort of difficult acronyms to them. This is called a GLP-1 receptor agonist, a SGLT2 inhibitor, DPP4 inhibitor. You can see that there's different target sites within the body that influence how sugar is handled in the body that can be influenced by certain medicines. The net effect of these different types of classes that might also include insulin and other kinds of pills is that they will all result in lowering of blood sugar. So that's a given for everybody. Some will have a bigger effect, like insulin is probably the strongest medicine that we have to really push sugar down, while there are some of our older pills that have been used in years past that really only have a very mild effect on blood sugar. We've said that some medicines will have an effect on lowering blood sugar, and to no surprise, if we look at insulin as one example, that the insulin is the one that has the greatest effect on bringing sugar down. Therefore, it has the greatest risk of pushing sugar down too far and having these hypoglycemic episodes where you may get low and jittery and shaky and sweaty and these sorts of things. Clearly not pleasant, but the other side of it is that some people certainly need insulin if they have type 1 diabetes, usually the onset of diabetes at a younger age where there is no insulin produced in the body. But some people with type 2 diabetes may also need insulin later on in the cascade of their condition to really get the sugars under control. The good news is that these newer kinds of diabetes medications that fall into these categories, and we're going to talk about them a little bit more, they have a pretty good effect on sugar lowering. They are rarely associated with making sugar go too low. That is, that they kind of bottom out and stabilize at a normal level. And the other really interesting thing about these classes of these newer medicines is that they tend to help one lose some weight, usually several pounds or a few kilograms, which can certainly be positive all the way around. And then the final part about why these newer medicines are actually quite of interest, and we'll spend a bit of time talking about them, is that they have been demonstrated in a number of very large trials recently to actually positively affect heart outcomes. That is, that they reduce the chance of having heart attack or stroke or ending up in hospital because of a heart complication. So these are the ones that are gaining a fair bit of interest recently in terms of being nice choices for people living with diabetes, especially if heart disease is present or if heart disease is a major concern. And this other kind of practice flow diagram from the Diabetes Canada guideline will take us through like the algorithm. And this kind of takes one through of how we as a healthcare practitioner might think about diabetes management. And we'll certainly start with those very good fundamental health behavior interventions: eating well, getting active, managing weight to the extent possible, using both of those strategies, thinking about how far we are from our A1C target. And remember, we started the conversation by saying that there is this nice relationship. The higher the sugar level, the higher the risk of heart disease. If you're very far above the target, like 7% or so, if you're very far above the target, then we should be using a couple of medicines, maybe right from the start. If you're close to the target, then we can take small steps and move along from there. The other question that's been added to the most recent version of the Diabetes Canada guidelines that came out a couple of years ago was to ask that question of whether heart disease is actually present right now. And that if it is, then we start to move down that pathway of looking for medicines that have some proven effect in prevention of cardiovascular conditions. And that's kind of the new exciting parts of where we go with this. Okay, so if we dive in a little bit further into medication options if we're living with diabetes, here are some key messages from our national guideline. The first choice for most people living with diabetes, type 2 diabetes, if we're starting out, is to use a medicine called Metformin. This is a very safe medication. It's been around for, gosh, like 40 or 50 years. It is very inexpensive. And some older studies from 20 or 30 years ago actually suggested that if you use metformin as opposed to other medications and brought sugar down, that there were some possible benefits in reducing heart attacks. So in all of the newer studies that have been done in the last couple of decades, metformin is kind of the baseline medicine that's offered to everybody with type 2 diabetes. And the way that it works is also quite attractive. That is, it works by making your body respond better to the insulin that's already in your body, so that you just use the tools that you have more effectively, as opposed to if you inject insulin, you just push extra insulin into the body, or other things that kind of squeeze more insulin into the system. This one makes use of what you've got better. And it also can reduce the amount of sugar or glucose that gets produced from the liver. So it's trying to balance things out much more nicely for your system. We've known about this for a long time, and some of you might have had this experience that if you start off with a really high dose of metformin from the get-go, that your stomach may rebel, your stomach and bowels may rebel, and you may experience nausea and diarrhea and feel rather unwell. Of course, nobody likes to feel that way. Good news is that this tends to get better over the course of a couple of weeks as your body gets used to the medicine. The other side effect that we always think about with any diabetes medicine is causing sugars to go too low. And for this medicine, it does not cause low blood sugar in most people and does not cause weight gain. So all of this makes this an ideal first line choice as a glucose lowering medication. If metformin and the healthy eating and exercise are not enough to control blood sugar, then we'll think about adding something in addition to that. And as those previous tables told us, there's a number of options from this category of medicines called the DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors. These medicines will be known by these kind of last suffixes in their names. This should be allogliptin, linagliptin, sitagliptin, saxagliptin. You get the nomenclature here. So they are used in some people. They work modestly well in terms of lowering blood sugar by increasing the insulin response after you eat a meal. Normally, after you eat something, your stomach senses this and signals the pancreas to say, I need some insulin to be kicked up so that we can make use of the sugar that's part of our meals. So this kind of augments that cascade. They're nice in terms of their side effect profile because they don't cause weight gain and they have a low risk of lower blood sugar. But as we said, their effect on blood sugar is kind of medium in the scale of other medicines. And um, with this class of medications, they've been shown when they've been looking at cardiovascular outcomes, they're not harmful, they're not beneficial, they're kind of neutral. So it may not be the first choice that one would go for all of those reasons if you had to think of adding something on. It's not bad, but maybe not the next choice after metformin. In distinction, these medicines that are called GLP-1 receptor antagonists, glucagon-like peptide, GLP-1 receptor antagonists, these are injectable medications, although there is a new pill version of these that will be coming out soon. These medicines increase insulin levels, which comes out of the pancreas, which helps blood glucose come down, and glucagon, a hormone that raises glucose, it keeps that down as well. So these kind of accentuate the body's response to the meal again. Because you can get a fair bit of medication into the system through an injection, they actually have a pretty strong effect on glucose lowering. So they seem to be quite attractive that way. If you're very far from target, then this would be a nice option. Their side effects also are very interesting in that for many people, weight loss has been seen with these medicines, sometimes as much as 5 kilograms or 10 pounds, which can be quite substantial for some people. And there is a low risk of lower blood sugar that is associated with this. So strong effect, weight loss, low risk of low blood sugar. The downside is that it's an injection. And the other really positive thing that has been seen in a couple of recent studies is that they can also lower the risk of having heart problems down the road, especially for medicines like Liraglutide or Dulaglutide. So a couple of the options within this category have been demonstrated to lower the risk of heart problems. So it makes these a nice choice for some people if you're able to manage the notion of injecting a medicine. The other major group of medicines that's become quite popular these days as an add-on in persons living with diabetes, especially when heart disease is also a concern, are these medicines called SGLT2 um, um, inhibitors. The idea is that our bodies handle sugar all the time. Sugar comes to us in the form of food, and because of some hormonal stressors in our bodies, sometimes sugar actually gets produced within our body, say from the liver. Sugar is actually floating around through our blood system all the time and is being filtered around in the kidney. That's the kidney's job, is to filter and sort of cleanse all the blood that we have. Sugar actually gets filtered out through the very tiny blood system within the kidneys. And if we just left it like that, then we would be dumping out sugar all the time in our bodies. Now, the way that we evolved, evolutionary wise, I think when our kidneys were constructed, I think physiologically it was determined that it would be a good idea, instead of pouring out all the sugar from our body, it might be a good idea to hold on to it. And if you think from an evolutionary perspective, then we don't waste our calories this way. Understanding how this actually works is quite interesting. It led some very bright scientists to figure out, well, that's how the kidney works under normal conditions, through a transporter called the sodium glucose loop transporter. And the thinking was, well, gosh, if I'm living with diabetes, one of my problems is not holding on to sugar for kind of survival reasons, but I'm actually holding on to a lot of sugar. And then maybe it would be a good idea to actually get rid of some of that sugar into the urine. So if I know that this is the transporter that's responsible for making me hold on to sugar, one interesting intervention that I can offer is to block that sugar transporter. And by doing so, when sugar is filtered by the kidney, it passes into the urine by blockade of this transporter. So there's at least 3 of these medications that are available now. One is called Canna Glyphlosin, another is Dapagliflozin, another is Empagliflozin. You get it again, that there's this interesting naming convention with these sorts of medicines. So interesting kind of ideas on how these medicines will work. The idea is that we can lower the body's sugar. We'll take out some fluid as well, so that there might be a less accumulation of fluid in the body, and there'll be some reduction in blood pressure on top of this. So it's an interesting kind of mechanism. It's kind of attractive in that way. The downside of this sort of medication is that sugar, when it gets into the urine, not such a bad thing, but when the urine gets down to the bladder or the genital areas, and if there's a lot of sugar that's kind of sitting around there, um, it becomes a bit of a breeding ground for fungus and yeast. Gosh, that sounds nasty, but it is something that's been observed in studies of people who were using these medications. Now, it doesn't happen to everybody, but it's something that we always warn people about if you're going on to one of these kinds of medications, that the way that's going to work is it's going to block this sugar transporter. You're going to dump some sugar. It's going to lower your body sugar, lower your fluids, lower your blood pressure. Therefore, it's important that you drink enough water to keep things flushing around. And we want you to watch for the possibility of developing infections in the genitourinary areas. Okay, so why are we excited about this vis-a-vis the discussion around the heart? Well, here's a few examples of clinical studies of diabetes medications and the heart. As an example of that last category of drugs, the SGLT2 inhibitors, empagliflozin is just one example. It's not the only one, but I'm just showing you this for illustration. When empagliflozin was put into a clinical study of people who were at high risk for heart disease or living with heart disease, the red line shows people who received medication. The black line are people receiving placebo. There were about 4,600 people receiving the medication. About 2,300 received placebo. They were followed over a period of 4 years. And this axis, the higher this line goes, this denotes people who experienced bad things like dying of a heart problem, having a heart attack, or having a stroke. And you can see that the black line is higher than the red line over the period of 4 years. This means that people who received the active medication empagliflozin had a lower risk of one of these bad cardiovascular problems like dying from heart disease, a heart attack, or a stroke. And the reduction in risk was about 14% over the period of 4 years. And when this study came out, it was quite revolutionary in that there hadn't been similar evidence in the past that choosing a certain kind of diabetes medication might actually lower your risk of bad cardiovascular events from happening. And this was an interesting breakthrough in that thinking. And it led then to the discussion that this type of medicine might then be preferred if you're living with diabetes and you're at risk for a heart problem. The other member of this family of SGLT2 inhibitors, Canna Glyphlosin, also was looked at in a similar kind of study over several years. A few thousand people get the drug, a few thousand people get the placebo. They're looking at these bad cardiovascular events to happen. The yellow line that denotes placebo is much higher than the blue line that denotes the medication Once again, over a period of 5 to 6 years, the reduction in risk of a bad vascular event happening is about 14%. Again, remarkably consistent. It doesn't take away the risk completely, but it is interesting that if one had to choose a diabetes medicine, then this one might be the one to go with. And then similarly, the injectable therapy called Liraglutide. This was an example of the GLP-1 receptor antagonist, the one injected. Strong effect on blood sugar, bringing down weight over a period of time, low risk of low blood sugar. Same kind of deal, 4 years. Drug versus placebo, several thousand people on drugs, several thousand on placebo. Those that got drug, lower risk of bad things happening, remarkably consistent number. In this case, 13% lower risk of bad things happening if you took one of these medicines. So it's really then this information has informed that practice guideline that you might choose medicines in either of those categories. More recently, the other interesting kind of overlap between heart disease and diabetes has been looked at in newer studies. This medicine, you can tell the name, Glyphlosin. I know the glyphosins now. Gosh, that's one of the family of drugs that it belongs to the SGLT2 family, the ones that cause me to dump sugar into the kidneys, pee out sugar, bring down fluid, lower blood pressure. And for persons who are living with a condition called heart failure, these are some of the problems that they experience. That is, people with heart failure and reduced pump function of the heart, they tend to hold on to fluid, hold on to salt, have too much fluid in their bodies, get short of breath for this reason. So there were some very bright scientists who thought, well, we've got these diabetes drugs that can actually help us get rid of some fluid through the kidney mechanism. And they decide to study this in persons with heart failure and living with diabetes, but also people with heart failure, but who did not have diabetes as well, which is very interesting. And once again, you're getting actually very good at looking at these kinds of graphs. And you can see that in medical research, they all look kind of the same, and that across the bottom is time. And this is 1 year, 2 years, 3 years, 4 years of time. And on this side is counting up the number of people that had a bad cardiovascular event. The additional thing here was if you landed in hospital for heart failure. And the dotted lines refer to people who were receiving placebo. The solid lines refer to people that were receiving medications. If we'll focus on the red lines, first of all, because that's where most of our action is, that if you had a condition called heart failure and you were receiving the placebo medication, then your risk of landing in hospital was fairly high, like 5% every single year. You'd have that risk of landing in hospital. But if you instead look at the solid red line here, that's if you've got one of these interesting diabetes medications, dapagliflozin, and that really dramatically reduced the risk of cardiovascular death or hospitalization and through the effects of that medication. So very interesting how the choice of a diabetes medicine can influence what happens with our hearts going down the road. And let me just carry on there and move this into any question that you might have at this point. If there is anything that comes up, please go ahead and type it. I will see it. If not, I recognize that it's late at night on a school night, so to speak, so I won't hold you here. Let me just end then by saying the recap of this session was, approaching diabetes care is really important. Getting control of the sugar in addition to all of those other items in terms of risk reduction is really critically important. And then what we've been seeing with newer studies of these kind of innovative diabetes medicines is that certain choices can actually improve our heart outcomes as well as our diabetes outcomes. If you're living with diabetes and heart disease, and if you had any questions about which medicines you're on and why, please do follow up with your physician and or pharmacist and have that chat. Okay, I haven't seen any questions come in, so I'm going to assume that you've had enough in this interaction. We'll just remind you that we'll have the next installment in this series coming up next week on Monday morning. And we thought that in the lineup of our usual heart topics, we would also like to bring up some COVID-related topics, and a area that is on all of our minds these days are the vaccines directed against COVID-19. So we're going to put together hopefully what will be an interesting and engaging session for you. What are these vaccines? What is the technology behind them? What are the outcomes that we're hoping to see with them? Unfortunately, I can't promise that you'll get a vaccine if you watch that session in short order, but I'm hopeful that all of us will get through the vaccine cycle in the near future. So please join us next Monday for this conversation about the COVID-19 vaccines. All right. Well, thank you very much for your time and attention this evening. I hope that was of use to you, and we'll look forward to seeing you at our next juncture. Okay, take care.